over to you.
Thank you. Good evening, doctors. We welcome you to this experience sharing program on managing PPH, case studies from labor room. This program is brought to you by Hetero Healthcare. Hetero Healthcare, to give you a snapshot, we have got 25 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and a presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, API, and FDFs in the world. We have Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and we have distinction of bringing 4 biosimilar products within 5 years of initiation. Today's program, we welcome you to this experience sharing. We have got honorable speaker, Dr. Sudesh Doshi with us. Sir is gynecologist and obstetrician from Pandharpur. Welcome, Dr. Doshi. And over to you. I'll run the presentation.
Thank you. At the outset, I'm very happy to share my experience with Carbetocin with all you people who are all joined from all over the places. And as we all know, we obstetricians, we always have a nightmare is the postpartum hemorrhage. All of us experience this, our heart throbbing, speeding to our tachycardia going to 200 before the patient's tachycardia goes to 120. And we have this new drug Carbetocin in our armamentarium now. The tonic PPH, as we have always studied in our UDG days, PG days, has been always been tackled in different ways. We have medical management of this PPH, and we have the surgical management of PPH. And apart from PPH, at the same time, we have to manage the shop, and we have to manage the OT, the staff, and nowadays we have to manage the relatives and the politicians who are at the threat to us. So all of us, we don't want to have PPH. So PPH will have either a prophylactic treatment or a therapeutic treatment. So just to go through the slides, just a smaller revision of all the basic things which we all of us know, but it's better to have a revision. It makes us more accustomed to the procedure. So as we all know, PPH is loss of 500 ml of blood following vaginal delivery and 1000 ml after cesarean section. What happens in atonic PPH, as we know, naturally when the placenta comes out, uterus is supposed to contract and or the fibers retract and the fibers are crisscross, so they clamp the vessels and the blood stops. But when unfortunately there is some atony due to some or other causes, all the causes we know that huge uterus, distended uterus like twins or polyhydramnios or a prolonged labor or a labor induced or a patient in sepsis, in such cases we get atonic PPH. But the unfortunate part of it is that in 50% of cases, there is no high risk factor for a patient of PPH. So every patient who's delivering either vaginally or abdominally is likely to undergo PPH. So we are always ready, our OT is always ready, our staff is always ready with tackling PPH. So next slide, please. Now, why PPH? We know it's unfortunately yet common. It has been recorded in the history. As we all know that Taj Mahal is the biggest monument of PPH. When Mumtaz Mahal, she died in her maybe umpteenth delivery, 10th or 12th delivery of PPH. And in her memory, the Shah Jahan built a Taj Mahal. But now we don't want Taj Mahal to be built on dying women, but we want to save them from dying, and we will all ready for it. So maternal mortality, leading cause of maternal mortality, accounting for 30% of maternal deaths is PPH. Maternal mortality ratio in developing countries is around 240. In India, we have brought down to almost 170. Or 130. In Maharashtra, we are fortunate enough. We should congratulate ourselves for bringing that maternal mortality rate to less than 15 Maharashtra and Kerala. So we have very fewer number of mothers dying due to PPH or even dying due to causes related to delivery and puerperium and ANC. But still, 25% of global deaths take place in India, and 2/3 of these attribute to PPH. So we have to take care of PPH. Next slide, please. So we know what is etiology of postpartum hemorrhage, as we were told by our great teachers, 4 T's, that is tissue, thrombin, trauma, tone, and we know. So when it is tone, when there's uterine inability to contract, which causes continuous bleeding, there is where the role of this drug Carbetocin comes. For thrombin, we know when there are bleeding coagulation disorders, We have other means to treat trauma when there is a difficult forceps delivery. Nowadays, no one does forceps delivery. It is unfortunate that our younger generation is losing fast the art of applying forceps, but it has its place in this the treatment of obstructed labor. But when there is trauma or maybe a difficult vaginal delivery, when the baby is bigger one and the trauma to the vagina or vulva or cervix or to the uterus and tissue, when there is retained product of conception, the placenta and abdominal fluids of the placenta. So today we'll be mainly dealing about tone, that's uterine atone. Next slide, please. So clinical findings in PPH, we all know we will be diagnosing PPH by vigilance, as we call as the fourth stage of labor. When after the placenta comes, we have to be very vigilant. We have to see whether the patient is bleeding. If the patient is soaking a 50 the normal size pad within 5 to 10 minutes, then we will have to hurry and look for atonic PPH. And we have to set the alarming signs everywhere. Everyone has their antennas up, and we know the protocol. Call for help, to put in 2 intracats, call for blood, call for anesthetist, take the patient to the OT, look for any trauma, look for atony, and you have to start giving medical management of the drug. We also look for the signs of shock also. There is circulatory collapse, the BP goes down, the pulse comes up. As we know, there is an index where the pulse is more than the systolic BP, then the patient is likely to have PPH. There is increasing abdominal girth in case of ruptured uterus or something like that. Loss of uterine contractions. We don't feel the uterus to be contracted, maternal tachycardia, vaginal bleeding. And when we say there is slight fall in the systolic BP or market fall, or there are palpitations, this is in this tachycardia. These are the degrees of PPH and degrees of shock, as we all know. Next, please. Next slide, please. So initial evaluation is the rapid assessment of patient status with pulse, blood pressure, PV bleeding, patient's pallor, patient's respiratory rate, patient if they're cold and clammy hands, temperature of the patient. So assessment of vital signs and blood loss we have to see. Examination of type of uterine, assessment of entire genital tract for lacerations, hematomas and signs of uterine rupture, manual examination for rectal placental tissues, assessment with bedside ultrasound if available. But ultrasound doesn't help much in case of atonic PPH. As we know, it is clinical. Ultrasound will only help in case of APH where we want to diagnose a ruptured uterus or some cases, but most of times rather than ultrasound, clinical management would be more. Or if you do a per examination in case of PPH, you will get the placental tissues which are remained. Ultrasound will be of less help because it will be very difficult to get the ultrasound machine to the bedside or in the OT and to have a person who will be able to interpret the ultrasound, because you will be busy with managing the patient on doing the ultrasound. So ultrasound, though theoretically okay, but practically it will be difficult and less useful in case of atonic PPH. Assessment, evaluation of uterus to check for uterine inversion. This is also important. So laboratory assessment, nowadays we all have a protocol, at least in my hospital, that when the patient comes in labor, whatever her hemoglobin may be, we always send for a CBC and a cross match of the patient, so that every patient of labor, my labor, has a cross matched 1 unit readily available, so that we don't have to run to the lab when the patient is having PPH. So if a PPH is diagnosed, at the time you're going to take out blood samples, then literally or practically if the blood bank is even near to you, to cross match the blood and to send the blood to your OT, the patient will be dead by that time. So it is a good practice which I have been doing for last almost 15 to 20 years, that whenever a patient comes in labor, you give a CBC, you know the blood, you know the platelets, you know the count, and also at the same time you cross match 1 bottle of blood in the blood bank so that you have it readily available. So that if you call the blood bank, the bottle will be available within less than 10 to 15 minutes. So you have to look for the hematocrit, the platelets. Next, please. So when there is a pure uterine tone, or there is a tear or a trauma or the retained tissue, we will have all the clinical findings. For poor uterine tone, we have that the uterus is flabby, relaxed, and you don't get the cricket ball consistency. The uterus fundus may be filled above the umbilicus because uterine cavity is filled with blood and clots. And as you said, for the full blood count and abdominal ultrasound if necessary. And what is the management? As we all know, most of the times we are doing the prophylactic management or active management of third stage of labor, ATMSL as it's called. Previously, we used to give injection methylargometrin at the delivery of the anterior shoulder, but methylargometrin has its own side effects. So nowadays, for last 10 to 15 years, the WHO is advocating for the active management of third stage of labor, which is prophylaxis for a PPH. It's 10 units of intramuscular oxytocin or 10 units of oxytocin in IV drip after the delivery of the baby. So that will help to prevent PPH. But for the treatment of PPH, yes, the first thing what you can do is you can put two IV lines, and what are the ultrasonics which are available to us. All gold standard is oxytocin 20 units, put in half a liter or 1 liter of ringer lactate. You give it fast. If it is not acting, you can think of methyl ergometrin. We have been using so many years, though now the students are not using it, but still I believe in methyl ergometrin. The cricket ball consistency which you get with methyl ergometrin, there is the best thing. But if the patient is having PI, then hypertension, then we cannot think of methyl ergometrin because it is likely to cause a stroke because of hypertension. So ergotalgolides, oxytocics like the oxytocin which has been there, now carbetocin which has come, and plus prostaglandins. Like prostaglandins in work for 10 to 15 years in late 90s and early 2010. But because of their side effects like vomiting, loose motion, some patients may be allergic to prostaglandin. Nowadays, we also have that whenever we give prostaglandins like misoprost or carboprost, we see that patients have typical V's, and you can see that noise or voice because of prostaglandin. So we are afraid if the respiratory system is go to bonkers, then it will be difficult. So these are the all drugs in our armamentarium, and today we'll be more talking about carbetocin. For retent tissues, we know that we do a PV, we see blood clots and retent placental tissues, we can remove it, manual removal of placenta can be done. And if there is a tear or trauma, if it is uterine rupture, we have to open the patient to the OT. If there is a vulval tear or vaginal tear or vulval hematoma, we have to tackle it down either under anesthesia or with the local anesthesia. Other things which are talked of theoretically is pelvic artery embolization or uterine artery embolization, but it is not available. It is available only if you have a cath lab in your hospital premises, and they are available very few places. And the thing is, at that time when the PPH is occurring, and if you want to give pelvic arterial embolization, uterine arterial embolization, then at that weird hour, and we know there's always PPH occurs at midnight or 3 o'clock in the AM, when the anesthetic is not available and the interventional radiologist may not be available, the cardiac OT may be shut down because it may be fumigated. So practically it becomes very difficult to do a pelvic or uterine artery embolization. But it is a good thing. I have seen once or twice in my life being done, and it works wonders. But it is not available, accessible, affordable to everyone. So if it is a coagulopathy, then you should be identifying coagulopathy. Take a help of hematologist, the intensivist, and we should be parallel with resuscitation. Next slide, please. So now carbetocin, as we all know, is a rationale for development of carbetocin in new heat stable formulation. Oxytocin had its limitation. As we know, oxytocin is not heat stable, and oxytocin, if kept out of a refrigerator, may not add work time. Carbetocin is coming in two forms. One form is heat stable, other is non-heat stable. So again, same will be applicable if carbetocin is not stable at room temperature, and then its efficacy will go down. It may not work when we want it. So carbetocin is now available in the room temperature stable form and convenient vial presentation. Oxytocin and argon should be kept in the refrigerator to avoid degradation, that we all know. Heat stable formulation of oxytocin is currently not available. Yes, we all keep oxytocin in the refrigerators. Previous formulation of carbetocin should be stored between 2 to 8 degrees. Resource poor countries do not have the cold chain transport and storage capacities. Now, yes, almost all of us, we do have a separate refrigerator to be kept in our OT, but maybe sometimes the door is open, the temperature maintenance is sometimes a problem. It may not be 2 to 8 degrees, but it may be 15 degrees sometimes. And the doors are kept open, the staff may not look after it. So we always would prefer a heat stable formulation, which would be good at room temperature. So carbetocin, which is heat stable at room temperature, has shelf life of 24 months at 30 degrees centigrade and 75% humidity. Now we have to take it to mind that it is stable at 30 degrees. So it is again not up to room temperature. For places like Solapur, Pandharpur, Chandrapur, and Nagpur, the room temperature may go beyond 35, 37, or 40 degrees. So again, we have to keep it refrigerated. But for all practical purposes, we will have to keep at 30 degrees and for 75% humidity. It avoids cold chain storage policies and logistics. It is provided in mind. Next slide, please. So, use of uteronic agents. As we know, one is given as a prophylactic, that is active management of third stage of labor. Another is treatment of PPH. So now, uterotonic is a molecules oxytocin, carbetocin, argometrin, symptometrin, that is carbetocin, oxytocin plus argometrin, and misoprostol are the drugs which can be used. So at the time of administration, at the crowning of baby's head, at the time of entry shoulder of the baby, at the end of second stage of labor, or following the delivery of placenta. So prophylactic use for prevention of PPH or active management of third stage of labor, and therapeutic use is management of PPH. Next, please. So carbetocin is a next generation drug for PPH management. As we say, it is modified form of oxytocin. So it was making several modification of the oxytocin structure, and it prolongs the half-life. Oxytocin is a very smaller half-life, as we know, around 20, 30, 40 minutes. Whereas change in the structure making to carbetocin reduces the enzymatic degradation. So drug, it is a synthetic long-acting analog of oxytocin. ऑक्सिटोसिनचाच आपण सावत्र बहुनक्षत चुलत भाऊ किंवा त्याच्या भाऊकीतलं एक औषध आहे असं म्हणूया. The therapeutic indication is prevention of postpartum hemorrhage due to uterine atony. So as per today, the World Health Organization, it has not given indication for carbetocin as for active management of third stage of labor. The therapeutic indication is prevention of postpartum hemorrhage due to uterine atony. And posologen administration, it is a one vial which contains 100 microgram of carbetocin in 1 ml solution for injection. Next slide, please. So clinical evidence is that carbetocin is non-inferior to oxytocin. आता हा थोडा शब्दांचा खेळ असतो फार्मास्युटिकल प्रोडक्ट्स मध्ये. फार्मास्युटिकल कंपनीज असंच करतात. ऑक्सिटोसिन पेक्षा चांगलं आहे असं म्हणत नाही, पण ऑक्सिटोसिन पेक्षा वाईट नाहीये. म्हणजे निदान वी आर ऍट पार विथ टू ऑल्सो. थोडक्यात असे नवीन प्रोडक्ट मार्केटमध्ये आता हे मार्केटिंग स्ट्रॅटेजीज असतात. जसं की आपण म्हणतो की आपली पोरगी काळी कधीच नसते, सावळी असते. तशा पद्धतीने नवीन आणलेले ड्रग, हे ड्रग मी टू असतं, मग ते पहिल्यापेक्षा खूप चांगले. कसं चांगले त्यांना रंगवून रंगरंगोटी करून सांगावंच लागतं. So there was a champion trial where it was carbetocin hemorrhage prevention, the largest clinical death prevention of PPH. आणि त्या स्टडी डिझाईन मध्ये नॉन इन्फिरियरिटी डबल ब्लाइंड रँडमाइज ट्रायल. आता हे शब्द जे असतात, डबल ब्लाइंड, रँडमाइज, नॉन इन्फिरियरिटी, ज्या लोकांनी थोडासा क्लिनिकल रिसर्च केलाय, ज्यांनी PSM मध्ये थोडासा अभ्यास केला होता, ते नंतर जे क्लिनिकल ट्रायल्स त्यांना या शब्दांचा अर्थ बऱ्यापैकी कळतो. पण हे थोडं शब्दिक जरी असलं तरी ठीक आहे. ते ऑक्सिटोसिनपेक्षा खराब तरी नाही. ऑक्सिटोसिन खूप चांगले असे त्यांना म्हणता आलं नाही, कारण त्यांनी स्टडी डिझाईनच तसं केलं. मग त्याच्यामध्ये काय केलं, टू कम्पेअर द इफेक्टिव्हनेस सेफ्टी ऑफ इन्व्हेस्टिगेशन स्टेबल कार्बेटोसिन टू ऑक्सिटोसिन इन प्रिव्हेन्शन ऑफ PPH आफ्टर वजायनल बर्थ. आणि साधारणपणे 30,000 स्त्रियांमध्ये केलं. सो दिस इज अ गुड नंबर. चांगले ट्रायलच्या मोठ्या नंबर्स मध्ये असल्या पाहिजे. 10 आणि 5 ट्रायल करून उपयोग नाही, पण 30,000 लोकांचं त्यांनी केलं. आणि प्रायमरी आउटकम त्यांचं काय बघितलं त्यांनी, प्रपोर्शन ऑफ वुमन ब्लड लॉस ऑफ ऍटलीस्ट 500 ml or the use of additional uterotonic agent, and proportion of blood loss of 1,000 ml at least. म्हणजे काय की तुम्हाला PPH होते असं वाटलं, तुम्ही ऑक्सिटोसिन प्रोफायलॅक्टिक दिले किंवा कार्बोटोसिन प्रोफायलॅक्टिक दिले, आणि त्याच्यामध्ये तुम्हाला जर 500 ml पेक्षा वजायनल डिलिव्हरीला आणि 1,000 ml पेक्षा जास्त सिझेरियन सेक्शनच्या डिलिव्हरीला ब्लिडिंग झालं, तर मग PPH प्रिव्हेंट झालं असं म्हणता येईल. किंवा मग तुम्हाला वाटलं की नाही बाबा एवढ्याने भागत नाही, आपल्याला लगेच मिथार्जिन किंवा प्रोस्टाग्लॅन्डिन किंवा मिझोप्रोस्ट काहीतरी द्यायला पाहिजे, हे त्यांनी आउटकम त्याच्यातनं बघितले होते. नेक्स्ट ट्रायल. मग कार्बोटोसिनची इफिकसी किती आणि ऑक्सिटोसिनची इफिकसी किती, की 500 ml पेक्षा जास्त ब्लड लॉस किंवा जास्त जर तुम्हाला अजून एखादं एक्स्ट्रा एजंट वापरावं लागलं, तर कार्बोटोसिन किंवा ऑक्सिटोसिन वापरल्यानंतर सुद्धा साधारण 14 ते 15% लोकांना तुम्हाला हे वापरावं लागलेच आहे. म्हणजे आपण बघतो की नेहमी एक 4 एम्प्युल ऑक्सिटोसिन किंवा युनिट ऑक्सिटोसिनची आपण एक ड्रिप सोडतो, तरी पण कधी कधी नाही PPH थांबत किंवा PPH होते असं वाटतं. त्यावेळेस आपण एक्स्ट्रा मिथाइल आर्गोमेट्रिन किंवा प्रोस्टाग्लॅन्डिन काहीतरी देतो. तर तुम्ही कार्बोटोसिन वापरलं तर ते ऑक्सिटोसिनच्या बरोबरीनेच ते राहते. सो नॉन इन्फिरियरिटी वॉज एस्टॅब्लिश. सुपिरियरिटी आपली एस्टॅब्लिश करण्यासाठी काय व्हायला होतं की ऑक्सिटोसिन मध्ये 15% PPH होते, तर कार्बोटोसिन मध्ये 5%, 10% वगैरे व्हायला होतं, पण तसं नाही झालं. ब्लड लॉस मोर दॅन 1,000 ml दोन्हीकडे तेवढाच सारखाच आहे. अँड ऍटलिस्ट वन अँटिसिपेटेड AE ऍडवर्स साईड इफेक्ट, तर त्याच्यामध्ये दोन्हीला साईड इफेक्ट साधारणपणे तेवढेच आहे, की बाबा काय होतं किंवा पेशंटला कुठे टॅकिकार्डिया होईल किंवा फिवर येईल किंवा उलटी आल्यासारखं वाटेल, तर ते जे ऍडवर्स इफेक्ट जे होते ते तेवढेच होते आणि सिरियस ऍडवर्स इफेक्ट तेवढेच होते. तर थोडक्यात कन्क्लुजन काय की कार्बोटोसिन वॉज नॉन इन्फिरियर टू ऑक्सिटोसिन फॉर द प्रिव्हेन्शन ऑफ ब्लड लॉस at least 500 ml or the use of additional uterotonic drugs. तर ऑक्सिटोसिन इतकंच हे कार्बेटोसिन चांगलं आहे असं त्यांचं स्टडीज मधून लक्षात आहे. त्यामुळे बऱ्याच कंपनींना आता कार्बेटोसिन मार्केटमध्ये आणलेलं आहे. नेक्स्ट स्लाइड प्लीज. सो पोखरण रिव्ह्यू काय करतं, तर पोखरण आपल्याला सगळ्यांना माहिती आहे अनेक ठिकाणच्या अनेक ज्या स्टडीज असतात ते एकत्र करतात. त्याचं अगदी आपण म्हणतो की साखरेचं साल काढल्यासारखं खूप डिटेलमध्ये अनालिसिस करतात सगळ्या पद्धतीचे. आणि त्यांनी 11 स्टडीज, आता हे डेटा थोडा कमी बघा, 2635, 30,000 एवढं नाही, पण त्याच्यामध्ये त्यांनी काय म्हटले, फॉर वुमन हू अंडरगो सिझेरियन सेक्शन कार्बोटोसिन रिझल्टेड इन द स्टॅटिस्टिकली सिग्निफिकंट रिडक्शन इन द नीड ऑफ for therapeutic uteronics compared to oxytocin. Also, carbetocin is associated with less blood loss as compared to oxytocin plus methyl aromatase in prevention of PPH for women who have vaginal delivery and associated with significantly fewer side effects. तर कोकरेनवाले म्हणतात की कार्बेटोसिन हे ऑक्सिटोसिन पेक्षा सुपिरियर आहे. नेक्स्ट. सो गाईडलाईन्स अँड रेकमेंडेशन्स काय आहेत, नेक्स्ट स्लाइड प्लीज. की गाईडलाईन्स रेकग्नाइज द बेनिफिट्स ऑफ कार्बोटोसिन फॉर प्रिव्हेंटिंग युट्राइन ऑटोमी. आता वेगवेगळ्या ज्या संघटना असतात हे त्यांच्या गाईडलाईन्स असतात की बाबा तुम्ही हे वापरा, ते वापरा, ते वापरा. त्याच्यामध्ये WHO ने जे दिलंय की पीपीएच प्रोफायलॅक्सिससाठी त्यांनी वन ऑफ द फॉलोइंग म्हटलं. यातलं तुमच्याकडे जे काही उपलब्ध असेल त्यांनी 5च्या 5 गोष्टी दिल्यात. आपण नेहमी जे वापरतोय त्याच्यामध्ये ऑक्सिटोसिन वापरू शकता, आपण 20 युनिट जे देतो, किंवा कार्बोटोसिन वापरू शकता, मिझोप्रोस्ट टॅबलेट पण दिले त्यांनी, आर्गोमेट्रिन किंवा मिथाइल आर्गोमेट्रिन म्हटलेले, आणि ऑक्सिटोसिन आणि मिथाइल आर्गोमेट्रिन कॉम्बिनेशन. म्हणजे थोडक्यात WHO हे 5च्या 5 गोष्टी वापरू शकता असं म्हणताय. याच्यामध्ये फक्त कार्बोप्रोस्ट नाहीये बघा, कारण कार्बोप्रोस्ट आपल्याला प्रोफायलॅक्सिस साठी देता येत नाही. बेबी बाहेर आल्यानंतर किंवा प्लासेंटा बाहेर आल्यानंतर आपण कार्बोप्रोस्ट देतो. पण कार्बोप्रोस्ट आपण दिलं, प्लासेंटा जर आतच असेल तर प्लासेंटा अडकण्याची शक्यता असते, त्यामुळे कार्बोप्रोस्ट याच्यामध्ये नाहीये इंट्राव्हिस्कुलर. त्यानंतर सोसायटी ऑफ ओबीगॅनिक सोसायटीज ऑफ कॅनडा जे आहे त्यांनी कार्बोटोसिन 100 मायक्रोग्राम आयव्ही बोलस म्हटलेले. त्यानंतर न्यूझीलंडची जी सोसायटी आहे त्यांनी ऍक्टिव्ह मॅनेजमेंट थर्ड स्टेज ऑफ लेबरमध्ये प्रोफायलॅक्टिक युट्रोटॉनिक्स द्या म्हटलंय, पण त्यात त्यांनी कुठल्या औषधाचं नाव घेतलेलं नाही. फिगो सांगते कार्बोटोसिन इज वन ऑफ द रेकमेंडेशन फॉर पीपीएच मॅनेजमेंट. जे फिगोने पीपीएच मॅनेजमेंटसाठी सांगितले, प्रोफायलॅक्सिससाठी नाही सांगितलेलं. जर्मनी, ऑस्ट्रेलिया, स्वित्झर्लंड म्हणतात की कार्बोटोसिन 100 मायक्रोग्राम स्लो आयव्ही द्या. आणि फ्रान्सची ओबीजी सोसायटी कार्बोटोसिन वापरा असं म्हणतात. थोडक्यात जगभरातल्या सगळ्या ज्या सोसायटी आहेत किंवा चायनीज सोसायटी सुद्धा, या सगळ्या लोकांनी कार्बोटोसिन रेकमेंड केलेलं आहे. म्हणजे तुमच्याकडे ज्या काही 3, 4, 5 गोष्टी आहेत त्यात कार्बोटोसिन वापरू नका असं कुठं म्हटलेलं नाहीये, पण ते तुम्ही आधी जे पहिलं वापरतात ते वापरलं तरी चालेल, त्याच्यावर कार्बोटोसिन सुद्धा वापरू शकता. नेक्स्ट. So my experience with the carbetocin, the smarter, superior, safer choice in PPH management, for last 1 year almost, I have shifted from the oxytocin giving 4 ampules to I have shifted to carbetocin, especially in cases of cesarean section. You give carbetocin in once the I am little faster at doing cesarean section. So once I have taken the incision on the uterus till the baby comes out, the anesthetist, the in charge person gives oxytocin intravenously 100 microgram bolus, and I find that the placental delivery almost occurs immediately. So by the time we wait for the 1 minute delayed cord clamping, that's 60 seconds. So wait, by that time the pulsations are stopped in 60 seconds. When we have cut the umbilical cord and we hand out the baby to the pediatrician, the placenta, most of the times I have seen that the placenta delivers spontaneously. So it is a good drug for active management of third stage of labor. With oxytocin, what happens, we have seen is that oxytocin we give, then we have to wait for the placenta to separate. We give requires some time, maybe sometimes 2 minutes, 2.5 minutes, or 3 minutes, or 4 or 5 minutes also. And in that time, in a hurry, we are tempted to do a manual removal of placenta, which we should not do. But sometimes it happens that we are in such a hurry that we are not ready to wait for some time, 2.5 minutes, a very long time when you've already taken the incision. So that time we are sometimes compelled by our mind to do a manual removal of placenta, which we try not to do. So the superiority of carbetocin comes in that the placenta delivers spontaneously immediately after that. So I found it very useful for cesarean section for as an active management of third stage of labor. In cases of doing vaginal delivery, generally when the patient is in second stage of labor, I generally prefer to give a little oxytocin ka dhakka. So I have that oxytocin drip running. So I don't use carbetocin at that vaginal delivery for active management third stage of labor because my oxytocin is already running for maybe for the induction of labor or for augmentation of labor. And these two drugs compete for the receptors. And as we say, once carbetocin is given, all the receptors are blocked. And so you cannot use oxytocin again at that time. So for delivery, vaginal delivery, I have tried carbetocin in few instances for PPH. Oxytocin is given, but the oxytocin is not working. At that time, I have tried carbetocin for yeah, PPH management, PPH during vaginal delivery. And that time I have tried quite effective. But that time what happens is very difficult sometimes to pinpoint which drug has acted because we are in such a hurry and it is a panic situation where you want to treat the patient, you don't want the patient to deteriorate at any cost. So what happens is generally we start the oxytocin drip. If oxytocin drip is not working, then we give also methyl ergometrin also. We put misoprostol tablets for rectally also. At the same time, we can give carbetocin also. So the only problem with carbetocin is if you are given carbetocin in the first line of management, they say that it has a half-life for a longer time and for half an hour, you cannot use any oxytocin drug like oxytocin because the receptors are blocked. So that is the only point. But I have seen that whenever I give carbetocin as a in cesarean section for active management of third stage of labor, that time oxytocin will not act. So if the PPH occurs, which as you are going to occur in 15% of the times, as the study shows, that time I generally it is a cesarean section. So I resort to either methyl ergometrin or sometimes I'm a little more comfortable by doing a surgical management like taking a CHO stitch or bilateral uterine artery ligation and it gives time for the drug to act like methyl ergometrin. So carbetocin, as if you're given as a active management of third stage of labor and still PPH occurs, that time I use either for surgical management or for methyl ergometrin. And so carbetocin is a good drug. The only bigger advantage is heat stable, but heat stable at 30 degrees. Sometimes our room temperatures may go beyond 35, 36, 37. As we know, in May and all, we have Solapur, Chandrapur, Nagpur going to 40 plus. So it is better to have a refrigerator. If it is refrigerated, not then it is good. The drug will act very nicely. So for at least active management of third stage of labor during cesarean section, I have shifted from carbetocin to oxytocin. My anesthetist is also very happy. Says carbetocin acts much better because he's a person who judges me and who is in the OT and who knows whether this he's the only second person who knows कि ये पहिल्यापेक्षा bleeding जास्त झालं का कमी झालं. So carbetocin is a good drug in our armamentarium, and always a option available to us to be used in place of oxytocin or even in spite of oxytocin. If it is not working, then we can use carbetocin. So my experience, overall experience has been very good with carbetocin. And yes, it is a good admit. You should have carbetocin in your PPH kit, as we all have been trained with Manyata training centers and government training centers, government jobs, everything. We don't want mother to die at any cost due to causes related to pregnancy. So in our PPH kit also, I have included carbetocin. Specifically why? Because our PPH kit, PPH bundle tray, whichever we have, generally it is not kept in the refrigerator. It is in a box, which box is very difficult to fit in the refrigerator. So there you cannot keep oxytocin in that PPH kit or PPH bundle. There you can keep methyl ergometrin or tablet misoprostol. So oxytocin is in the refrigerator, then it is not in the PPH box, so it becomes difficult. The 15-20 seconds, which are very important to get the oxytocin from the refrigerators. So I have included carbetocin in the PPH treatment kit, PPH management kit, PPH box, which we have eclampsia kit, because it is heat stable, and that is the biggest advantage of carbetocin over oxytocin.
Sir, generally you have used IV route or IM route?
IV. Because the drip is going out, I have given IV carbetocin.
And as you said, you have mostly used it in a cesarean section.
Yeah,
Sir, any adverse effect you have noticed, experienced?
Not anything major so far. Sometimes the patient may have vomiting or maybe a little dizziness, but that cannot be attributed specifically to carbetocin.
Okay.
Because patient is under spinal anesthesia, patient may be having little hypotension, patient is antibiotics have been given, but nothing specific to carbetocin. I have not any adverse side effect which could be significant.
And you are using carbetocin since how long?
Maybe last 1 year.
1 year. And that's what I said. Okay. Some questions, panel questions.
Yeah, sure.
What are the patient profile where you can anticipate PPH? Of course, PPH you can get in any patient, but in generally speaking, which patient should be careful?
Yeah, as I to I said in the presenting starting lines only, introductory lines only, that PPH, every patient is a potential patient of
Yes,
PPH.
yes, correct.
But yes, there are few patients who are high risk of PPH, are patient those who have a distended uterus due to polyhydramnios, twin pregnancies, multiple pregnancies, big babies, then patients who have been induced for delivery, patients who have prolonged labor, then patients who have anemia, they are also more likely to have PPH and they are more likely to land up in complications of PPH. आपल्या स्कूटरची टाकी फुल असेल तर लांब पल्ल्यावर जातात, पण स्कूटर आधीच रिझर्व्हर असेल तर रस्त्यातच बंद पडणार. So patients who have anemia are more likely to land up in complications of PPH. Patients of coagulopathy, known coagulopathy, as we know, they would likely to land up in PPH. Patients who are on aspirin, and unfortunately they'll end up in delivery before the aspirin has been stopped for some or other reason, like abrasion or something, they are likely to land up in PPH. Patients with PIH, eclampsia, they are more likely to land up in PPH. But as we're all said and done, any patient is likely to go in PPH.
Yes,
And
yes.
as we know that 50% of patients have no risk factor and they still land up in PPH. Primary gravida are likely to more land up in PPH, and grand multiparas, fourth gravida, fifth gravida, sixth gravida.
Okay.
Nowadays we don't see much of them, but they are also likely to land up.
Patients with fibroid, patients with diabetes are also likely, I suppose.
Yeah.
An interesting thing you said, patients who are on aspirin. Now, as I mean, today many patients are on aspirin despite being getting pregnant. So I mean, in
No.
an emergency.
Actually, they are put on aspirin as a therapeutic dose to prevention of PPH. Those patients who will get uterine artery Dopplers done in the early pregnancy, who have a higher Gestosis score, who have PGLF and screening done, and those patients who are likely to have pregnancy-induced hypertension, high risk, these patients are started with aspirin as early as 12 weeks. They're kept on aspirin till 34 weeks. And generally, we stop aspirin at 34 to 36 because we are anticipating delivery at that time. So unfortunately, sometimes patient goes into preterm labor.
Yeah,
that time we have not stopped aspirin. These patients are like that.
And
It is not for cardiac thing. It is for the PIH, pregnancy-induced hypertension. That low dose aspirin is started around 150, 25 or 150 milligrams.
Excessive amount of amniotic fluid could also predispose because of the size of the uterus becoming more.
Yeah. Polyhydramnios, simple stretching of the uterus is overstretched. Polyhydramnios, or maybe twins.
Yes, twins.
Triplets. Yeah.
Can we use Carbetocin in case of retained placenta? Your experience, sir?
As far as retained placenta, I have not used Carbetocin for retained placenta, but yes, I think it has a potential to be used because all these years we have been taught that one of the treatments of retained placenta is to keep a patient on a low dose low dose oxytocin drip, a small oxytocin drip running for maybe 2 hours, 3 hours, 4 hours, 5 hours. If the placenta is retained and if the patient is not bleeding, then you can start with oxytocin drip, and some maybe patient the placenta separates after a long time and then comes outside. Because we all have experienced that in our residency days. Sometimes the patient was referred as retained placenta from a primary health center to a tertiary center. And because the means of communication, the roads, means of transport were not there, patient would take 2 hours, 3 hours, 4 hours to reach our civil hospital. So by that time, the placenta would be in the vagina because the oxytocin drip is running. And by that time, retained placenta is not retained placenta, but just the placenta, the vagina. So yes, Carbetocin has a potential because it is an oxytocin drug and not a drug like methyl argometrin or a prostaglandin, where the whole uterus contracts, where the action of oxytocin is the upper segment will contract and lower segment will expand.
Relax.
So if the Carbetocin is mimicking the action of oxytocin and not of argometrin or a prostaglandin, then Carbetocin may have potential to be used as retained placenta. I have not tried yet. Maybe if I get opportunity, I will try and discuss with friends.
And in case of Rh negative mothers, this could be a serious problem in the interiors where blood, I mean, if you said like cross matching is not done, suddenly Rh negative mothers.
The question is not because of Rh negative mother. The question is in Rh negative mothers, we avoid giving oxytocin or methylargometrin because we don't want the Rh negative, the baby, if it is Rh positive, we don't want the baby of blood of the baby which is in the placenta to go into maternal circulation. That's why we don't want to use methylargometrin. But that apart, when there is PPH, sir salamat to pagdi pachas. If the mother survives, then only sensitization.
That's
so oxytocin, yes, we use, but methylargometrin, people say we should not use it in Rh negative mothers because of the whole gush of blood goes into the maternal circulation before the placenta separates. So our carbetocin should be used judiciously rather than using the active management of third stage of labor. In PPH, yes, you can use it because by that time the placenta is gone, the baby's blood all is gone, and it will not go into maternal circulation. Yes, carbetocin can be potentially used in Rh negative mothers. So far, I have not yet come across a mother who has got sensitized, but that will be a long-term study. We have to go for 5 years, 10 years, and we have to look for the papers that whether carbetocin was used in that mother, whether she got sensitized in this pregnancy or not. It will take a long-term study.
Can a doctor use carbetocin for prevention of PPH? In fact, you have already mentioned this. If oxytocin is used for labor induction,
I generally prefer to switch to another class of drug rather than using the same class of drug. If one thing is not working, oxytoxics are not working, we have got action like oxytocin, then it would be wiser to go towards methylargometrin or a prostaglandin rather than trying carbetocin again. That is should be a logical thinking. I have no clinical experience of it, but that should be the logical thinking as far the theory goes.
Different receptors and different mode of action.
Yeah.
In which cases you're using IV in almost all cases.
Yeah,
do you think IM has got a place?
Well, that would be for people like you in the pharmaceutics and
No,
to find out. But
I'm talking about those. I'm talking about the interiors where it's difficult to get.
No. See, in India, in Maharashtra at least, or every interior, at every smallest town of 1,000 village also, there is a person who can put in IV. So there are no remote places now where IV
is not
access
possible.
would not be available. Or actually, to tell you frankly, WHOच्या ज्या गाईडलाईन्स आहेत त्याच्यामध्ये पेशंट डिलिव्हर होत असताना आयव्ही लावा असं कुठंही लिहिलेलं नाहीये.
ओके.
इंट्राकॅथ लावा किंवा स्काल्प लावा असं डब्ल्यूच्या कुठल्याच गाईडलाईन्स मध्ये कुठंच लिहिलेलं नाही नॉर्मल लेबरला. पण सगळ्यात आधी पहिली गोष्ट आपण करतो ते आयव्ही लावून घेतो, कारण त्याच्या पेशंटचं समाधान होत नाही, आपल्याला काहीतरी केल्यासारखं वाटत नाही, आणि आयव्ही ऍक्सेस पेशंटला पीपीएच होताना ड्रग्ज देताना मेडिसिन आपल्याला लागणार आहे. पण डब्ल्यूच्या गाईडलाईन्स मध्ये कुठेही लिहिलेलं नाही की आयव्ही लावा म्हणून. पण आपल्याकडे आयव्ही लावणारे उपलब्ध आहेत, सगळीकडे उपलब्ध आहेत. त्यामुळं अगदीच रस्त्यात कुठेतरी बाई कुठेतरी डिलिव्हरी झाली, फक्त इंजेक्शन मिळालं, सुई मिळाली, तर पण त्या औषध दुकानात जर सिरिंज मिळत असेल तर इंट्राकॅथ नक्कीच मिळेल. फक्त एक आहे, काही वर्षापूर्वी काही ग्रामीण भागात काही मेडिकल ऑफिसर्स होते, ते स्वतःवर एक पीपीएच किट बरोबर कॅरी करायचे, आणि त्यांच्या पीपीएच किट मध्ये एक सिरिंज असेल मिथाइल 4 अँप्यूल असायच्या. रस्त्याने जाताना कुठे लागलं तरी वापरतील अशा पद्धतीने. मी त्या मेडिकल ऑफिसर सरांचं नाव विसरलो, ग्रामीण भागात कुठेतरी काम करणारे मेडिकल ऑफिसर होते, आणि त्यांनी ते त्यांच्या स्टाफला सगळ्याला ट्रेन केलं. बाकी काही नसेल, तुमच्या खिशात तंबाखूची पुडी नसेल चालेल, पण तुम्ही जर मेडिको असेल तर तुमच्या खिशात मिथर्जिनची अँप्यूल असली पाहिजे.
लाईफ सेव्हिंग ना, वन्स अपॉन अ टाइम.
लाईफ सेव्हिंग.
As this adverse effect of carbetocin, you have not seen anything adverse effect?
नाही, फारसं काही आपलं नेहमीच असतं, ते वेगळं काही फारसं दिसलं नाही.
If a patient is not responding adequately with carbetocin, what next? Well, in your order of sequence, sequence असेल तर ह्याच्यानंतर what additional nutrotonics you can use?
I would prefer to go for methylargometrin. आणि ऍश्युअरन्स कसं सिक्वेन्स करत कोणी थांबत नाही, अर्ध्या तासानंतर पेशंट मेल्यानंतर देण्यात काहीच गमत नाही. इफ कार्बेटोसिन इज नॉट ऍक्टेड ॲडिक्वेटली, then I would prefer to go to another group of drugs rather than going for oxytocin. Methargin, prostaglandins nowadays we keep it reserved last source, कारण प्रोस्टाग्लॅन्डचा एक सोर्स आपण मेझोप्रोस्टोल टॅब्लेट्स रेक्टली देतो, त्याची ऍक्शन उशिरा सुरू होते पण प्रोलॉंग ऍक्शन राहते. सो आय वुड प्रिफर टू गो फॉर मिथाइल अँड रेक्टल मिझोप्रोस्टॉल. आणि जर असेल अवेलेबल, इफ यू आर व्हेरी हॅपी, तुम्ही वापरत खूप उत्साही असाल, तर जर पेशंटचं ऍबडॉमेन ओपन असेल तर तुम्ही प्रोस्टाग्लॅन्डिन इन द कॉर्न ऑफ युट्रस देऊ शकता, इंट्रामायोमेट्रल कार्बोप्रोस्ट देऊ शकता.
Advantage in terms of overall, carbetocin over other uterine problems.
ओव्हरऑल म्हणजे मिथाइल आर्गोमेट्रीची कम्पेअर केलं तर मग ज्या पेशंटला हायपरटेन्शन आहे त्यांना आपण देऊ शकतो. मिथाइल आर्गोमेट्रीने उलटी होतेच होते. रादर मिथाइल आर्गोमेट्री देऊन एखाद्या पेशंटला उलटी नाही झाली तर मी त्या अँपूलची एक्सपायरी डेट बघतो का फ्रीजमध्ये ठेवलं नव्हतं का बघतो का दुसरं काय दिलं बघतो. उलटी हे एवढा मिथाइल आर्गोमेट्रीशी कनेक्टेड आहे की ते ऍक्ट झालं नाही. पीआयचे पेशंटमध्ये देता येतं, उलटी होत नाही फारशी, त्यामुळे ते ओव्हर आहे. आणि ऑक्सिटोसिन बरोबर म्हटलं तर हीट स्टेबल आहे. प्रोस्टाग्लॅन्डिन कार्बोप्रोस्ट म्हटलं तर कार्बोप्रोस्टने पेशंटला स्पाझम येतो, थंडी वाजून येते, ताप येतो, लूज मोशन्स होतात. तसं कार्बोटोसिननी होत नाही. आणि मिझोप्रोस्टलाही थोडासा ताप वगैरे नंतर येऊ शकतो, पण मिझोप्रोस्टेक्टली देता येतं. तर बाकीच्या कम्पॅरिझन मध्ये हा त्याचा ऍडव्हान्टेज आहे. हीट स्टेबल आहे, उलटी करत नाही, ब्लड प्रेशर मध्ये देता येतं.
सिंगल डोस आहे त्यात. Should carbetocin be kept as a reserve drug or should be first line?
मला वाटतं रादर दॅन कीप इट एज अ रिझर्व ड्रग, इट शुड बी यूज फर्स्ट लाईन ड्रग फॉर थर्ड स्टेज ऍक्टिव्ह मॅनेजमेंट ऑफ थर्ड स्टेज ऑफ लेबर. आणि इफ इट डझंट वर्क देन शिफ्ट टू मिथाइल आर्गोमेट्री. रिझर्व्ह ड्रग ठेवायचं म्हटलं तर आधी जर ऑक्सिटोसिन दिलं असेल तर ऑक्सिटोसिन रिसेप्टर्सवर हे कितपत ऍक्ट होईल थोडीशी शंका आहे. पण मिथाइल आर्गोमेट्री वापरून जर नसेल इफेक्ट मिळत तर ऑक्सिटोसिन तुम्ही वापरलं नसेल तर मग कार्बोटोसिन देऊ शकता. पण इट शुड बी युज एज अ फर्स्ट लाईन रादर दॅन किपिंग इट एज अ रिझर्व्ह ड्रग, असं मला वाटतं. आता या संदर्भातले स्टडीज कमी फारसे वापरले अकॅडमिक्स मध्ये मी फार नसतो, पण लॉजिकली थिंकिंग मेकॅनिझम ऍक्शन जर बघितलं तर असं बरं वाटतं.
Faster onset of action as compared to oxytocin.
या
सर, ऑक्सिटोसिन ने तुम्ही कधी एडीएच रिलेटेड साइड इफेक्ट्स बघितलेत का? रिटेन्शन ऑफ
कसे
वॉटर
म्हणलं?
वगैरे, एडीएच रिलेटेड वॉटर रिटेन्शन, युरिन
नाही, वॉटर रिटेन्शन होण्यासाठी ऑक्सिटोसिनने कसं आहे, फॉर वॉटर रिटेन्शन ऑक्सिटोसिन द डोस इज ऑलमोस्ट रिटेन्शन ऑकर्स आफ्टर 80 to 100 युनिट्स ऑफ ऑक्सिटोसिन.
ओ माय गॉड.
आणि तेवढं ऑक्सिटोसिन कोणी
कोणच देत
देत
नाही.
नाही. म्हणजे काय होतं, पूर्वी ज्यावेळी दुसरं कुठलंच ड्रग उपलब्ध नव्हतं, फक्त ऑक्सिटोसिन किंवा ऑक्सिटोसिनच, मिथाइल आर्गोमेट्रिन क्वचित मिळत होतं. तुम्ही म्हणाला ज्यावेळेस तुम्ही रेसिडेन्सीमध्ये होता, इंटर्नशिपमध्ये, हा. मग त्यानंतर जर ऑक्सिटोसिन काम करत नाही तर पटकन मिथाइल आर्गोमेट्रीला द्या ना. दुसरी गोष्ट उपलब्ध असताना ऑक्सिटोसिनचा ओव्हरडोस होण्याची शक्यता कमी असते. दुसरा ऑक्सिटोसिनचा ओव्हरडोस पूर्वी जो व्हायचा तो म्हणजे लेबरच्या पेशंटपेक्षा ज्यावेळेस सेकंड ट्रायमेस्टर अबॉर्शन्स लोक करत होते, अनोमलीसाठी असेल किंवा इतर काही इंडिकेशनसाठी, त्यावेळेस बऱ्याच वेळेला आयव्ही ड्रिप लावली जायची आणि मग एक ड्रिप लावली, दुसरी ड्रिप लावली, त्या पेशंटला अबॉर्टायला 12 तास, 16 तास, 18 तास, 24 तास लागायचे. त्यामध्ये कधी कधी त्या ऑक्सिटोसिनचा जर मेळ कोणी ठेवला नाही, किती दिले काय दिले, तर ऑक्सिटोसिन ओव्हरडोस व्हायचे. पण आता ऑक्सिटोसिनचा ओव्हरडोस जनरली होत नाही, कारण आपण जनरली पटकन दुसरीकडे शिफ्ट होतो. बाबा, जसं रेल्वेचा डबा समोर आहे, ह्या डब्यात नाही तर दुसऱ्या डब्यात जा, तिसऱ्या डब्यात जा. त्या डब्यात ज्यावेळेस घुसावं लागणार तिथं गर्दी चेंगराचेंगरी होणारच. पण आता तसं होत नाही.
सर, हे सेकंडरी पीपीएच इफेक्ट कार्बोटोसिनने
Secondary PPH generally is due to either infection or due to erosion of some vessel. मग त्याच्या वेळेस सर्जिकल मॅनेजमेंट किंवा पॅकिंग किंवा बलूनिंग हे जास्त उपयुक्त राहील. कार्बोटोसिनचा रोल तसा थोडासा कमी राहणार, कारण त्यावेळेस काय युट्राइन रिट्रॅक्शन हा फारसा प्रॉब्लेम नसतो. त्यावेळेस अटोनिन नसते जनरली सेकंडरी पीपीएच मध्ये. सेकंडरी पीपीएच मध्ये इरोजन ऑफ वेसल किंवा कुठेतरी स्टिच निघालं त्यातनं ब्लिडिंग असतं. अटोनिन जनरली सेकंडरी पीपीएच मध्ये नसते.
Rupture असतं किंवा any other cause. What is the role of an anesthetist vis-a-vis gynecologist in choosing a drug?
हे अनेस्थेटिस्टनी गायनेकोलॉजिस्ट आता नवरा बायको सारखं, तुझ्या वचन करमत नाही, तुझ्या वचन भांडल्याशिवाय जमत पण नाही. पण नाही, इट शुड बी जनरली दोघांनी म्हणून डिसिजन घेतलेला बरा असतो. काही गोष्टी अनेस्थेटिस्टला जबाबदारी आपण त्याच्याकडे दिली तर आपल्या मनावरचा भार हलका होतो. कारण किती एक्सपिरियन्स गायनेकोलॉजिस्टला कोणीही असला तरी ज्यावेळेस तिथं पेशंटला पीपीएच व्हायला लागतं त्यावेळेस आपलं मन, आपलं मेंदू काम करायचं बंद करतो. तो जो ब्लॉक असतो त्यावेळेस अनेस्थेटिस्ट तुमचा जर नेहमीच अनेस्थेटिस्ट असेल तर बऱ्याच गोष्टी स्पायनल लेवलला होत जातात. तो देऊन टाकतो, सांगतो सर मी बाबा दिलंय, हे दिलंय, तुम्ही तुमचं काम पुढं चालू ठेवा. सो द चॉईस ऑफ द ड्रग्स ऑब्व्हियसली द प्रोटोकॉल शुड बी देअर, की थिएटरमध्ये येताना की जर मिथाइल द्यायचंय, ऑक्सिटोसिन द्यायचंय, कार्बिटोसिन द्यायचंय, तर दोघांनी मिळून तो जॉईंट निर्णय घ्यावा आणि जो घेताना तो पेशंटच्या भल्यासाठी घ्यावा. त्यात
ऍब्सोल्युटली.
तुमचा इगो पॉईंट आणू नये, संगीत
अजिबात नाही,
मानापमान
अजिबात.
करू नये.
हाय, हाय, हाय.
पेशंटसाठी जे चांगले अनेस्थेटिस्ट घेईल, गायनेकोलॉजी घेईल, दोघांनी मिळून निर्णय घेतलेला चांगला असतो.
बरोबर.
तिथं अजिबात मानपान करायचं नाही. ज्या अनेस्थेटिस्ट सोबत तुमचा इगो पॉईंट होतो ना, त्या अनेस्थेटिस्ट तुम्ही दोघांनी एकत्र कुठली सर्जरी करू नका. तुम्ही तिथलं थिएटर सोडा किंवा अनेस्थेटिस्टला दुसरा बोलवून घ्या. ज्या अनेस्थेटिस्ट तुमचं जमत नाही त्याच्यावर सर्जरी करू नका.
बरोबर.
ॲज गुड एज दॅट. म्हणजे पेशंटच्या भल्यासाठी, आपल्यासाठी
येस येस येस, आपल्यासाठी. तुमचा ओव्हरऑल एक्सपिरियन्स म्हणजे वंडरफुल. टेक होम मेसेज फॉर द ऑडियन्स.
येस, कार्बेटोसिन इज डेफिनेटली एक सुंदर पर्याय आहे ऑक्सिटोसिनला. त्याच्यापेक्षा हिट स्टेबल आहे आणि ऑक्सिटोसिनच्या ऐवजी कार्बेटोसिन वापरायला काहीच हरकत नाही, एस्पेशली फॉर ऍक्टिव्ह मॅनेजमेंट ऑफ थर्ड स्टेज ऑफ लेबर. तुम्ही जर आयव्ही ऑक्सिटोसिन सिझेरियन सेक्शनच्या वेळेस दिलं तर माझा अनुभव बहुतेक सगळं सिझेरियन सेक्शन बरोबरच आहे, चांगलं काम करते. इट इज अ गुड ऑप्शन फॉर ऑक्सिटोसिन. वापरायला
थँक्यू.
काहीच हरकत नाही.
थँक्यू सो मच सर. इट वॉज व्हेरी इंटरेस्टिंग. शेवटला काय असतं, प्रॅक्टिकल एक्सपिरियन्स इज मोर इम्पॉर्टंट टू अवर डॉक्टर्स दॅन रादर दॅन थिअरी. थिअरी एक गोष्ट आहे, पण आपल्या डॉक्टरने वापरलेलं त्यात कॉन्फिडन्स बिल्डिंग जे आहे ओनली वेन अवर ओन डॉक्टर्स यूज. अँड आय एम शुअर
नाही,
डॉक्टर्स.
माझा एक प्रोटोकॉल आहे की बाजारात कुठलंही नवीन औषध आलं तर
बरोबर.
पहिले 1.5 ते 2 वर्ष मी ते कधीच वापरत नाही.
हा.
कधीच वापरत नाही. लोकांना वापरू देत, त्यांच्याकडनं फीडबॅक येऊ देत. कारण कुठलं मेडिसिन, फार्मा कंपनी शेवटी ज्यावेळेस त्यांनी संशोधनामध्ये एवढे पैसे घातलेले असतात, आपला तो बाब्या असतो, दुसऱ्याच ते कार्ट असतं. त्यामुळे ते मार्केटिंग तुम्ही करणार, त्यात तुमचं काही चूक नाही, त्याच्यावर सगळ्यांचं पोट पाणी अवलंबून असतं. पण तुम्ही जेवढं सुंदर मखरात आणून बसवलेलं असतं तेवढं ते चांगलं आहे की नाही हे प्रत्यक्ष आपल्याला वापरल्यावरच कळतं. मग भले ते फेरस फ्युमारेट असू दे, आयर्न असू देत, फेरस ग्लुकोनेट असू दे, नाहीतर कार्बोनेट असू दे, नाहीतर एफसीएम असू, काही असू देत, तर ते ड्रग थोडंसं नवीन ड्रग मार्केटमध्ये आल्यावर मी त्याच्या मागे कधीच जात नाही. 1-2 वर्ष तरी शांत बसतो. आय एम लिटल लेट युजर ऑफ एनी न्यू ड्रग इन द मार्केट. आणि नंतर मग बाजारात काय चालू अवस्था आहे, काय कॉन्फरन्समध्ये मित्रांशी हेच बोलणं करायचं आणि मग त्याच्यावर अंदाज घेऊन मग वापरायचं आणि आपण ठरवायचं.
बरोबर. पण इट्स लवली तुमचा एक्सपिरियन्स आला. आय एम शुअर द ऑडियन्स हॅज बेनिफिटेड व्हेरी मच. आणि तुम्ही एकदम लाईव्हली केलं सेशन सर. फॉर द पीपीएच असा टॉपिक आहे, इट्स वंडरफुल टू डिस्कस. पण देवाच्या कृपेने कोणालाही पीपीएच मिळू दे नको.
अगदी अगदी अगदी.
इट्स व्हेरी गुड टू डिस्कस. थँक्यू सो मच. थँक्स ऑल द ऑडियन्स हू कुड टाइम अँड अटेंड. Thanks marketing team, thanks sales team of Hitro for this support coordination. Thanks Nagadevi, thanks Manisha for all the
थँक्यू.
support. Sir, तुम्ही लॉग आउट करू शकतात.
हो,
थँक्यू. थँक्स सर. वंडरफुल सेशन. थँक्यू.
थँक्यू सो मच. किती लोक होते